And I appreciate everybody listening to this presentation. There's a lot of material, so I think Dan will tell you that I am reachable afterwards, and if you have any questions whatsoever, please feel free to ask me. Most of the people in the conference who've led this conference know how to reach me, and I actually do respond to my email. I have absolutely no disclosures, none. I wish I did, I guess, but absolutely none. I first want to explain a little bit about something that Dan brought up, is the Patient Education Office. I work for McGill University as faculty, and I also work as a director with a colleague of mine of the Patient Education Office, which is committed to these concepts, and I think the most important components of these concepts are understanding, because without understanding, you cannot make informed decision making, you cannot take care of yourself, and you do not know when to go back to your healthcare professional, what you need to do, as well as, of course, adhering to care regimens and navigating the system. So our focus is understanding. We do it a little differently than many people. We focus less on text and more on images, and I'll show you a lot of images. The focus is also, this is much easier to see than the screen, but I think it's important to recognize it's not a one-person deal. We're a small office, but we represent multiple perspectives. We have clinical content experts. I am a nurse by training, but I know very little about specific areas. I can't tell you very much about fertility prevention, post-chemotherapy, breast reconstruction. We depend upon content experts who feel that they are not communicating this specific information to patients for them to be able to collaborate in informed decision making. And it really is all about the patient. Our society has changed. People no longer are told what to do with respect to their health, but are active participants in their health. Just to highlight some of the bubbles, we have our clinical experts, we have our patients, and they are critical to the process. Because if we think we're communicating a concept and we're not communicating it properly, then we're not doing our job. We have pedagogy, which is a little bit of my domain, and it follows how do you teach? How do you teach the clinicians how to communicate? And are you teaching patients and their families and their caregivers the concepts that you want to communicate? We have, I say images, but we really have 4 artists who are not based in medicine, who had no experience in medicine before they began, but can clearly communicate concepts in images that we could not possibly do, going way beyond clip art. And of course, all of us depend upon the evidence and changes in practice. We recognize that changes in practice require almost immediate turnaround in our material. This slide I won't spend very much time on, but it highlights the complexity of what you do. Like an onion, when you tear one ring after the other, you realize there's a lot more happening in developing our patient education material than there is in creating a one-pager of do and don't. And so I'll leave this image with you, but I won't belabor it. The 5 areas that I want to discuss in the 15 maybe plus minutes that I have are the issue of literacy, health literacy, which is different than literacy because we're dealing often with a population who is either newly diagnosed, which is not the case here, but is learning to understand their disease. The issue of plain language, which we often refer to as readability, and speaks to the fact that people, content experts, are very used to writing at an academic level for publication, and that doesn't really work when you have a stressed patient. The issue of the development strategies that we use, and very closely aligned to the development strategies, are the pedagogical principles. They're not separate particularly, but the pedagogical principles are based in research. So the more that they align, the happier that we are. I'm going to start briefly with literacy. I'm not certain how many people are aware of the field, but literacy is a big issue for us because we want to make certain that we reach people and that they understand. The reading level, when we talk about levels 1, 2, and 3, level 3 compares to grade 4 to grade 6 in the ability to understand documentation that's given. That is not a particularly high reading level. We received some information from California because we do work for other places, and California, they're down to level 3. So it's not getting any better. So we have to look at ways to move around this. This is not a judgment, and it does not diminish the people who are looking at the text, the words that we use. It merely helps us understand how we can best communicate ideas. And I just wanted to point out in my last slide on literacy, we're not just talking about words. We're talking about statistics, numbers, risk assessments, complex problem solving, task analysis, quizzes. So there's a lot integrated into the world of literacy that we need to take in store. We need to understand before we say, here's your document. As a nurse, it's easy for me to pick a brochure and give it to a patient and say, this is what you need to know. But the most important thing is, does the patient and the family, the caregivers, the people who are, for whom this document is intended, do they understand? Is it clear? And is there something I can do as a healthcare professional to make it clearer? Health literacy is a little bit different. It's what we call stressful learning. I work in a domain with a surgeon where patients are well when they wake up in the morning, have a test, and end up with a diagnosis often of cancer. This is not the best time to learn, and there are stresses associated with it. So even if your literacy level is very high, when you talk about health literacy, it can be moderated by the circumstances and by learning. In Canada, 60% of adult Canadians do not have the necessary skills to manage their health adequately. The definition of health literacy has changed over the last 20 years to something that was really quite simple, to something, because patients go home not well, to something that is more complex. In the U.S., because we are closely aligned, and I would suggest that Western Europe is very closely aligned as well, 12% of adults had proficient health literacy. I'm not very good at math or technology, but that leaves a lot of people who have very little proficiency in health literacy. We need to work with them. It's not the onus on patients and their families to change or to increase their skill set. It's the onus on us to make certain that the material we create is understandable. I have a copy. I'm going to have a lot of images in this now that I've done most of the text. This is from MD Anderson, which is an excellent cancer facility in Texas, I think. And I would just point out it's not abnormal in the fact that everything is listed. So it's not tremendously exciting to look at, but more important, the language, the attention to the language is not there. They talk about mucosa, they talk about carcinoma in situ, they do not explain the disease in a way that I, as a patient who was newly diagnosed, would understand easily. On the other hand, what we do is something much more simplistic, like this. So colon cancer staging, stage 0, it's almost all an image. I think it's relatively easy to understand, and very importantly, it is plain language underneath it, and it's relatively simple. I come from Quebec. Quebec has 2 official languages, so translation is always an issue. With 2 languages, we hope that translation costs are less, because we have to worry about that if we use less words and more images. I'm going to go through this briefly, but you can see the transition of stages in colon cancer, and I would suspect that most of the audience is looking at the image, not at the words underneath it. If you were looking at the words underneath it, I hope that you would find that they were simple. This leads into the issue of plain language, and plain language is hard to define. It basically is language that is understandable. Often we use the word readability instead of plain language, and we often, when we're dealing with the clinician at the 5 minutes left? Oh dear. Okay, so we're dealing with the clinician at the end, and we ask the clinician, how would you explain this to the patient one-on-one, not write it up? So we talk about words and language. I'm going to have to go very quickly because I only have 5 minutes. The most important thing here is number 5. Who will this material be presented to? How will it be used, and by whom? And then plain language is writing for your audience in their language, as though you were speaking, explaining, or teaching. Here is an example of something that we use. I think it's really good, but we realize only after the fact that we're missing information. We cannot assume that a patient will know what 850 milliliters is. Other development strategies are the content headings and subheadings, which are very interesting, navigation, the clarity of the information, and most importantly, is it too much information? We know that as clinicians, you know an awful lot. Do you need to teach all of that to your patients? So here's an example of clarity and navigation, and you see it's in a circle. And there are cues, if you look at the stairs, about what to do if you have Parkinson's and you are going downstairs. And mostly, hold on to the banister. Little cues about did you know, which people find interesting, and the idea in development about interactivity. The more that you can do yourself, the more that you will understand. And reading gravity, how people actually read. So these are note pages. This is an example of coloring book for diabetics, young diabetics, where they actually color it in themselves. It was written by an 11-year-old, and they can interact with the material, and we hope that this will facilitate understanding. This is something in Mandarin that I think is relatively clear, irrespective of the language that's used. And this is something we did not do, which I find very scary because it includes everything. But how would you work your way through this? Would you be overwhelmed and turn the page, or would you try to figure out what it is that it means? It's very good, it's very inclusive, but not very friendly to a learner. Reading gravity means that most people read from the left and skip down to the right. So what you're doing as a developer are making it more difficult for them to do. These are just categorization. Make life easy. If you're going to have a website, I would suggest that you pay great attention to your metadata, because if you can intuitively search your website, then you are doing a favor to your patients as well as yourself. Is with respect to memory aids, this is something that you can tear off or print out, put it on your fridge, and you can remember this. The principles, I'm not going to go into them the time. Each of them are based on research, and each of them suggests that you want to follow a certain path. It's relatively intuitive, but it helps to have a conceptual framework or a research-based framework. Basically, a site like this is too difficult for somebody, generally, for somebody to remember. However, I'm going to leave on this. Another site, the Mayo Clinic site, is great. A lot of people go to Mayo. The language is very clear. The problem with the Mayo site is the multimedia. It's best if you integrate the images within the context of the site. At Mayo, the images are in one place and the words are in another. The problem with that is you have to keep going back and forth, and it makes it much more difficult to understand. The other problem I have with the site is it's selling lipstick, which may not be your primary reason for going into the site. This is our site. The idea of navigation is that you should be able to work your way through a site intuitively and site map. You should be able to have a bird's eye view of the site. If you want to do something in surgery or find out information in surgery, you should be able to click on surgery and know it's all there. Again, I'm going to skip the principles and just show you what we do with something that's relatively complex. I'm going to need 2 more minutes, okay? Just note on the top right-hand side, there's English and French. This is a series of images that show healthcare students as well as patients how a line is inserted, a PICC line is inserted. And we start with the line itself, and then we have it in graphics. Here you can see that every piece of the line is labeled so that if you run into trouble, you can ask your healthcare professional. It's the securement wings, it's the clamp. You have something that you can share together, and this goes through exactly how the site is inserted and where it actually lives. It goes right into the heart. This is another example of what to do and what not to do. Cues. Everyone visits a patient's room. These are the rules that the nurses want us to highlight. Again, principles. The idea here, and this is the last example I'm going to give you, is if you're a medical student, you've been given some prior domain knowledge. It's called the worked out principle. You can memorize the knowledge, but what are you going to do with it? So you have a patient who's been stabbed in the chest. He's in the ambulance. You have some options about what you can do with this patient. Each of these options, when you click it off, give you feedback. Once you get the feedback, you can move on. It allows you to take control. If you have enough information, you can manage safely what this case is. This is part of the same case. It gives you a visual representation about how to put a chest tube in. It allows us to give the students information that they need before they go to the simulation center and before they go into the clinical arena. So this is how you actually put in a chest tube if you need to. It also allows people to interact or to have interactivity. My last slide, and I think this is very important. How do you assess what you've done in order to ensure that you're meeting the needs of your patients, their families, as well as the concepts the healthcare professional wants to include. Does the content, is it comprehensive? Is the language clear? Are the images helpful? Are you giving too much or are you giving too little? Is the format right? This is online. This workshop is about online, but some people prefer print or some people go back and forth. You want to make sure that this information is available to everyone. And then you evaluate. Is it clinically correct? Is it correct from the perspective of the patients? Have you communicated what you want to communicate? And we highly recommend that you pilot because you're going to get very much more information afterwards. And that's it. How much overtime am I?
It's okay.
I'm okay? Thank you very much.
Thank you, Nancy.